Welcome back. This is Dr. Balone, and your next women's health issue will be that of chronic pain, found in Chapter 140. Looking at the definition of chronic pelvic pain, it's that of a continuous or episodic non-menstrual pain that lasts 6 months duration, affecting both men and women. It can be sudden or it can be gradual in onset. It occurs at or below the umbilicus. It's severe enough to interrupt normal daily activities of daily life. It can involve GI, urological, GYN, oncology, musculoskeletal, or a psychosocial system. The cause is often multifactorial, making it challenging for patients and providers. In up to 60% of patients, the cause is unknown. The subset of the population who are at increased risk for chronic pelvic pain have a history of physical or sexual abuse. The survivors that can develop long-term medical conditions associated with such abuse and trauma, such as they develop cardiovascular problems such as hypertension, diabetes, malnutrition, STD history, chronic pain, and incontinence. They may have mental health issues that include psychiatric disorders, educational difficulties with low self-esteem, trouble forming and maintaining relationships. Pelvic inflammatory disease, those with PID, that now it can proceed and lead to chronic pain around the pelvis and the lower abdomen. It causes them depression, insomnia. Ectopic pregnancy accounts for approximately 9% of women with PID experiencing chronic pelvic pain. Symptoms of chronic PID are lower abdominal pain, presence of fever, unusual discharge with foul odor from the vagina, pain or bleeding when having sex, burning upon urination, and bleeding between periods. Also, those with endometriosis, they can have severe pain in the pelvis during menstrual periods. Endometriosis is observed in 71 to 87% of women with chronic pelvic pain. Infertility is a common problem that results for women with endometriosis. It's diagnosed by imaging of the lesions in laparoscopy. There's no treatment that can prevent endometriosis from occurring, but a combination of the hormonal treatment and surgery can control the endometriosis. Hormonal suppression medications include the use of oral contraceptive pills, Implanon, anti-inflammatory medications such as NSAIDs, ibuprofen, Voltaren, Mirena, IUD, and hormonal suppression treatment, Zoladex. Interstitial cystitis. People with this IC have repeated complaints of discomfort, pressure, tenderness, and pain in their bladder and lower abdominal and pelvic areas. Various diagnostic tests are ordered to diagnose and treat this problem. The drug of choice for IC is polysulfate sodium. There's a newer drug, dimethyl sulfide, which is a liquid that's installed for 20 minutes through a temporary catheter into the bladder. Irritable bowel syndrome, IBS. 1/3 of women with IBS report chronic pelvic pain. Migraine, headaches, bladder discomfort, and dyspareunia. Common GI disorders include constipation or IBS. Pelvic pain that generally occurs is under the navel or lower back areas. Also can be rectal, vaginal, or peritoneal discomfort. It is not related to pregnancy or menstruation, though. Other reasons for chronic pelvic pain would be musculoskeletal disorders. The pain is around the pelvic area. The common condition leads to this chronic pelvic pain are such disorders as sacroiliac joint dysfunction, symphysis pubis dysfunction, a weak pelvic floor muscles, and joint immobility. Physical therapy is often helpful and effective. Post-surgical pain may develop after any surgical procedure and is common after abdominal and pelvic surgery with a prevalence between 10 and 40%. Pelvic nerves that are stretched during surgery or compressed afterwards may cause such pain. Post-surgical pain lasting more than 3 to 6 months after surgery is a problem and necessitates referral for pain control. Your clinical presentation of a patient with chronic pelvic pain may require multiple visits before you actually identify the chief presentation, the problem, and how you define it. You want to do a good, thorough med-surg history with an assessment of pain, the PQRST assessment, assess the relationship of pain to each organ system to see where your problem lies, identify associated events including complaints of fever, sweats, fatigue, anorexia, nausea, vomiting, and constipation. The physical exam and diagnostics. The practitioner will perform a detailed abdominal, pelvic, and back exam to see what the underlying problem is. The gold standard of investigation of chronic pelvic pain is to perform a diagnostic laparoscopy. Immediate referral is advised for patients with unstable vital signs and acute onset or increasing abdominal pelvic pain. Diagnostics include evaluation should be vaginal and cervical cultures that are obtained, a urinalysis, urine culture, CBC, pregnancy test, and an ESR, erythrocyte sedimentation rate for inflammation. A transvaginal renal ultrasound and laparoscopy, CT scan, or MRI may be indicated. Other differential diagnoses are looking at the musculoskeletal system. It may be a herniated disc disease, chronic pelvic tilt, degenerative joint disease, or a myofascial trigger point that's causing the CPP. Gastrointestinal IBS accounts for a large percentage of the CPP and would be a differential diagnosis. Urological diagnoses such as urethral syndrome, chronic urethritis, interstitial cystitis, urethral diverticulum, and bladder spasms should be considered. Gynecologic diagnosis of endometriosis and any psychological diagnoses if indicated. The management is supportive. You definitely want to look at the physical and emotional or psychosocial effects of CPP, living with this chronic problem. Pharmacological treatment would include NSAIDs, tricyclic antidepressants, anticonvulsants. Interventional treatment would be neurostimulation and laparoscopy. And some of your complementary and alternative medicine options would be cognitive behavioral therapy, acupuncture, cannabis for medical purposes, heat or cold, guided imagery, hypnosis, relaxation, massage, and spinal manipulation.